G'day and welcome back to the BroomeDocs podcast. And it is another month and another chat with Dr. Justin Morgenstern. We're going to do another episode of the First 10 and EM Journal Club. We're going to discuss, I think it's about 9 really nerdy papers this month, which covers a whole range of topics. There's a bit of resuscitation right through to some ethical conundrums in there. G'day, Justin. How are you, mate?
I'm doing very good. Pleasure as always to be chatting with you, and very excited to talk about very esoteric and very nerdy papers. My favorite time of the month.
Now, usually I say it's great to see you again, but I've actually been seeing quite a bit of you lately because not only are you a podcaster, but you're a YouTuber now as well, in that you have a channel, and if anyone wants to see more of this very handsome man, they can pop onto YouTube and check out some really nerdy discussions with Justin, discussing a lot of this sort of stuff, but in a very well-edited and crafted manner, and really throwing out some pearls there. Great work, Justin.
I mean, I appreciate it. I think I might be downgrading the full med experience. What they always say is I have a voice made for blogging and a face made for radio. So I'm not entirely sure this is the direction I should be going. But for right now, I'm having a lot of fun with it.
That's all right. Well, at least 2 of my 3 children want to be YouTubers when they grow up. So now I can say I know one at least. So that's good. You're pretty cool with the kids. Yeah, they used to want to be astronauts, but now they want to be YouTubers. And you've actually got content, which is
what we all dreamed of for our kids, eh?
But most of YouTube that I can see, there's no actual content. So you're way ahead of the pack already. So well done.
That's not how you make any money, though. I should be playing video games or something. I'm not sure how you make the big money, but it ain't talking medical education, that's for sure.
It seems to be taking things out of boxes. Seems to be very popular on YouTube as far as I can tell.
Oh, that's a good idea. Yeah, if anybody ever wants to send me a present, I will open it live on stream. How about that?
Yeah, absolutely. I'm a little bit worried about the sort of people that might be sending us presents, because we do talk about a lot of toxicology on this podcast. So, we could get some rosary beads or any sorts of things sent to us in the mail. So maybe we won't.
Take it back. It's all right. Send it to Perth, care of Casey, and he can open it for me, and I'll collect the good stuff at the end.
Actually, I work with quite a number of really good toxicologists, so maybe I'll get them to open it in their own office, which is just up the hallway from the ultrasound office, and we can deal with the fallout, because I'm sure they'll be fascinated by whatever comes. Yep.
All right, I like it.
Cool. All right, that's enough chit-chat. Shall we jump into some nerdy goodness?
Yeah, I think it's a good idea. And the first one's actually maybe the least nerdy of them all, some real resuscitation. It's the first RCT we've ever seen on high versus low dose nitroglycerin. So the paper is called High Dose versus Low Dose Intravenous Nitroglycerin for Sympathetic Crashing Acute Pulmonary Edema. And I don't know if our buddy Scott Weingart coined SCAPE or whether he was just the first one I ever heard it from, but I feel like SCAPE, it was the very first MCRIT episode a long time ago. Yep. And so that's the paper patients that we're looking at. Those really hypertensive flash pulmonary edema is what it was always referred to when I went through training. And it's an interesting, it's a single center unblinded trial. We can come back to some of the shortcomings, but an interesting trial. Randomized patients to high dose, which was a big bolus, 600 to 1,000 micrograms IV nitroglycerin bolus, followed by an infusion that started at 100 mics a minute, versus low dose, where you got no bolus and you started your infusion between 20 and 40 mics a minute. They did all this other stuff the patients needed. So everybody got BiPAP. And the outcomes were like dramatic. I got to tell you, when I trained, 20 mics was where you started nitro, and 40 was sort of considered high dose. And people would look at me like I was crazy at 100. And this is one of the reasons I fell in love with full med, because again, this was the very first MCRIT episode, and there was this weird cognitive dissonance of am I going to listen to some jerk on the internet and get my medical education from there, or am I going to listen to my local trainees? And it was great, because all of a sudden the world of medical education expanded dramatically. But it only takes 1 or 2 patients watching high dose nitro work in front of your eyes to realize this is not a bad idea. And I guess I can do the outcomes as well, but just like in terms of absolute benefit or numbers needed to treat, it's insanely better here. So at 6 hours, just in terms of patients who were feeling better, it was 65% versus 12%. At 12 hours, it was like 90 versus 20%, like not even close. Intubation was 20% versus 4% or something like that. So like dramatically better numbers if you use high dose nitroglycerin. Now this trial is far from perfect, but it is the best data we have with dramatic differences. So I wonder what your thoughts are before I do any ripping of this paper to shreds.
Yeah, no, I think it's a well, it's the only RCT that we have. Although, if I were to say to the listeners that Justin's going to be spruiking a single center unblinded open label trial that is only 54 patients in an Indian ED in New Delhi, and saying that we should all be doing this, that's just basically the whole EBM book has gone out the door. But it's one of those situations where it just makes sense, and we'll sort of need to see some numbers so that we can say that what we've seen with our own eyes over the years actually works. And the NNT on that you calculated is 1.4, and that's in that range of every time you do it, it works, and occasionally it doesn't. That's pretty much my experience with doing high dose. I think a couple of thoughts about this. I think that the term SCAPE is problematic, and I know that may be controversial in the FOAMed world because it puts that pulmonary edema in there, and I think that that's the wrong way of looking at it, because the pulmonary edema that we've all grown up, the old guy with chronic CCF and low cardiac output failure, it's a very different patient group to what we're dealing with in this group. In fact, they're pretty much never in the same group as far as I can tell. And I think that's where a lot of the falling down is, because a lot of people think of it as, this is just another version of the pulmonary edema that we see with the old crumbly every day of the week. And that causes a problem because people find it hard to get out of that lane of, we'll just start them on 20 mics per minute, or we'll give them a bit of Lasix and put them in the corner and see how they go, because it's a very different patient population. So, Justin, as I like to do on this podcast, I've coined a new acronym for us. Are you ready?
All right, I'm ready.
Okay, it's catecholamine-related acute pulmonary syndrome, because then you can say, this patient looks like crap. and that's what it is, because you walk into the resus bay and you look at the blood pressure, it's 200, and the patient's sweating bullets and they're breathing at 40 per minute. And you go, well, that's what it is. Because it's an end-of-bed diagnosis, really, isn't it? It's not hard to make. You have a listen, but it's very different to the other patients that we deal with all the time that have mild heart failure. So I think a lot of it's about labeling and working out which patients you do this correctly on. I had a chat to a few of my colleagues, including Dr. Cassidy, who was a guest on our show back in October when you were in Perth. You remember, Tom? Yep. And I asked everyone on the flight deck, I said, what's your starting dose? And they all said, we start with 100 mics or even more. He went higher, 150 or something like that. And yet, when I looked at the protocol that's in our resus bay, it says start at 20 to 40, which is... So there is that dissonance still, because it takes a long time to get these ideas in, and yet everyone's doing it, and it just seems to do nothing but cause this problem in medicine where we don't seem to be able to do what makes sense. And yeah, we need to start changing protocols, unfortunately.
Yeah, I think
is this paper enough?
Yeah, when I included this paper, I feel like it's not going to be news to a lot of docs, although it's interesting how information gets out there in the medical world, and I'm sure there's pockets who had never even heard of high-dose nitro. The problem is the distinction between doctors and nurses and the way that we go about things, and the level of evidence that we require to break beyond the written on paper protocols. And so having an RCT, I think, helps in that realm. We need to back all the way up again. Yeah, this is a single center unblinded trial, 54 patients. This is the kind of thing where you would say over and over again, these results seem too good to be true. Like there's a chance that this is not a realistic trial. But when you're going from an area where essentially before we were in complete fog of war, a complete gray area, you sort of have to go on best available evidence. Now, in many other situations, people are going to come back at me and say, hey, when there's been many new drugs on the market where you've had this level of evidence and you've completely shot it down. And I think the difference is a couple-fold. Number one, whose interests here? Nobody's selling us anything with this trial, right? This is just good old-fashioned science for the sake of science, not as an advertisement. But I think more importantly, there is a bunch of data already, not data in terms of benefit, but data in terms of safety. And you can look at the blog post if you want some more links, but it's pretty clear that in this specific population, the patients who are coming in very hypertensive, there's no harm that we're seeing from high doses of nitro. Lots of trials where there's basically no degree of hypotension, and a few trials where it's up to like 3 or 4% of patients get hypotension, but you turn off the drip and they're all fine with no long-term outcomes. So seeing as we know it's safe, and seeing as there's pretty strong physiologic reason to think it would be beneficial, I think This is slightly stronger than the average unblinded small single center trial. But you got to think of evidence, and we talk about this all the time. It's not black and white. It's not like this is a definitive answer. Evidence is always on a spectrum. So where's my needle pointing right now? Before this trial came out, I would have told you that, 60 or 70% that the benefits are going to outweigh the risks of high dose nitro. This pushes me higher than where I was before, but nowhere close to 100%. But if we're at 80 or 90%, that these numbers are, even if there was half these numbers are so good that this is my current protocol until we see what clearly needs to happen. And it'll probably only happen from Australia or New Zealand, where you get the big intensive care or emergency department RCTs. We need to see a proper blinded trial at some point. But this is enough for me to suggest practice change in the short term.
Yeah, it would be not that hard to do a blinded trial, because you just put up the same solution with different concentrations and run it essentially and titrate away, and that would work pretty well. It's interesting you say about the if this was a drug company sponsored trial, the patients in the low dose group actually ended up getting a lot more GTN over the course of their treatment than the ones in the high dose group, because they were still on the bloody drip 12 hours later, whereas the high dose group got better much quicker and they turned the drip off. And so the drug company would actually want you to use a low dose, which is kind of paradoxical, because you use a lot more of their drug if it was still worth anything. But I think nitro is worth almost nothing.
No, that's a classic pharmaceutical secret. They do not want cures. They just want management therapy, right? Because cures are a one-time hit. Vaccines don't make them any money. They want chronic disease management. Ozempic is the one that's making billions of dollars right now, because you're never not going to be eating that cheesecake for dessert. You need long-term management.
Cool. All right. Anything else to say about that, or should we move on to trial number 2?
I think that's probably enough for this, so we can move on. And if you have any IPAC or infectious disease doctors listening, you might ruffle a few feathers.
Yeah, I'll do the intro on this one, because got to say that this could get us into hot water. So this paper is entitled "Are Contact Precautions Essential?" inverted commas for the prevention of healthcare-associated methicillin-resistant Staph aureus. And this is in Clinical Infectious Diseases, September 23. Essentially, this is essentially a very long rant, as far as I can tell, by some people that don't like the latest version of the guidelines that were put out, talking about which sort of PPE we should or should not be using, or what should be essential versus what they just class as additional extras, in terms of what we should and shouldn't do for patients that either have colonization or infection with MRSA in hospitals. And I think this is one of those universal truths of modern healthcare in hospitals, is that every patient nowadays comes, I don't know about your computer system, but a little flashing triangle comes up in the corner of the screen depending on which version of MRSA the patient happens to be carrying, and then they get put in a different room and they have to wear different gloves, and essentially they don't get seen on the ward round because no one could be asked putting all the gear on and taking it off again. It's not so much a problem for ED, because we tend to just go in and see the patient once most of the time and then go out again. But it's a big problem for our nursing colleagues, and particularly for our inpatient colleagues, because you can sometimes be having to get changed 3 or 4 times per shift just to go and see the same patient over and over again with the yellow vest and everything. So huge waste. And is it really worth it? Does it change any actual outcomes? Tell me your thoughts, Justin, because I know what mine are, and my guess is that it probably doesn't. But I had a couple of questions for you, but I'll let you tell me what you think first.
Yeah, I mean, I think the important part of this paper is just the fact that they raised the question. And I think we can quibble about the actual evidence. They tell us, there's never been an RCT, and sure, that's one of those things that has been beaten to death, basically in the I don't know how to phrase it nicely, but in the medical deniers realm, there's no RCT, therefore we can't do anything. So that in itself is not an argument, but there are cluster RCTs that show no benefit, which I think is really interesting. But what to me the real crux of the question, where this paper brought a lot of value, was that they didn't just ask, is there a benefit? They put up the flip side of that argument. And I think all too often with interventions like this, we either assume there's a benefit or there's a tiny hint of evidence of benefit, but we forget about the flip side of that equation. So I thought the discussion of harms, to phrase the context of this really important. And you brought up a few already. just the difficulty of getting in and out of rooms. Apparently, there is some evidence that patients who are under these precautions get less contact with clinical providers. Clinical providers do less physical exams, spend less time in rooms. There's the other interesting societal stuff. All these gowns are made out of single-use petroleum plastics. Apparently, in North America, 10% of all the greenhouse gases come from medical supplies. So there's a bunch of interesting things on one side. If there is a benefit, like we do not want to be causing harm. We don't want to be spreading important infections from patients to patients. So that all seems fine for me. But it also just theoretically, like I know IPAC likes to have everything done. It doesn't make a whole lot of sense. I don't touch patients with my bare hands, so I'm going to use gloves anyway. But like the whole gown that actually hangs away from my body and is more likely to touch the patient's bed, the whole contact precaution thing didn't make a lot of sense. So wash your hands and wear gloves makes perfect sense. And maybe when you're, as these guys suggest, in a setting where there's an outbreak or rapidly rising MRSA rates, you got to do something else hospital-wide. This paper, if you're going to get into a strong argument, there's just not enough to definitively say one way or another. But I like it because it reminds us we have to phrase these questions in the broader context. You have to consider both the potential benefits and the potential harms. So that's why I wanted to throw it in here. Plus, I just like EBM rants. It's always a good thing.
Yeah, I had a question for you. I don't know I really understood this, but there was a section in the paper where they talked about the COVID period and when we were all doing, like, especially in my hospital, doing very judicious gloving and gowning. It was probably the best PPE I've ever done in my whole career was for that year or so where, like, every patient I went to see pretty much I was doing, like, fastidious gloving and gowning and paying close attention to which order I put everything on, which I took it off and washing my hands 4 times as I changed in and out of the gear. To my mind, that would be a good natural experiment to see whether PPE actually made a difference if you did it before and after. But reading this paper, it seemed like they think that was actually when the infections were worse. I don't know. What was your takeaway on that? Did you have a...
Yeah, I didn't have a good explanation. They do present some data. It's a good counterfactual because there is some observational data that says that you can put in these PPE things and rates go down. But you can imagine all the issues, the Hawthorne effect, etc. But they present a bunch of other situations where rates actually go up. And I think the basic thing is we just don't understand. We like to blame healthcare providers as being vectors, but I think we'll come back to this in a later paper. But I think a lot of this probably has to do with the design of hospitals. So is it really us? Is it the stretchers that you can't get in between? Like we're talking about, you don't actually have to transfer the bacteria, right? MRSA can transfer just genetic material between each other. And so you can take an MSSA and turn it into an MRSA pretty easily. And most of our killing devices are for killing the bacteria, but they don't decimate the genetic material. So I can imagine lots of ways that you could be transferring these little snippets that you need without necessarily eradicating the bacteria. So I think the bottom line is we just don't understand, which is one of the most dangerous areas of science. I think infectious disease has a good theory, but then you just make the assumption and you never push this further. I think that's what we really need at this point. If MRSA did not drop off the face of the earth, like we saw flu drop off the face of the earth for the 2 years that everybody was masking, that tells us we have a pretty good understanding of how that spreads. If MRSA did not disappear, it tells us we should be going back to the drawing board and doing some really basic science research. That to me is what it means. Redo our assumptions.
Yep, fair enough. So have a read of the paper. It's fascinating, and it comes down to a lot of that sort of day-to-day drudgery that we experience all in hospitals where we're dealing with infection prevention control, because it's not something that we as doctors are very good at. And it's probably something that our nursing colleagues probably spend a lot more time dealing with. But I think most of us are still pretty horrible at doing gloves, even when it is mandated. So anyway, carry on, and we'll move on to our next paper, which is an Aussie paper. Hey, the main reason
I just knew it was high quality. You asked for very high quality medical research, and so that's all I've been sending these days.
No, the reason I knew this was an Aussie paper is that all of the food products that they use are classic Aussie products. So I don't think they actually use it. They didn't use Vegemite at any point.
In there. I don't know.
Well, maybe that was the one they're missing. It's a viscous liquid, Justin. Maybe they should have used Vegemite. That could have been...
It might have been the answer. And then you'd have to stock it everywhere in the world. You guys could be making billions. I don't think we've even introduced what we're talking about. Now everybody's confused. This is the best podcasting we've ever done. It's fantastic.
All right, I'll do the intro then. So this was a group of New South Wales toxicologists, actually, I think. And the title of this paper is Home Therapies to Neutralise Button Battery Injury in a Porcine Esophageal Model in the Annals of Emergency Medicine, September last year. And I love the fact that the Australian researchers dropped the O on esophagus in order to get it through the American Medical Journal. So good on you, Aussies, for dropping your O. Well done.
You finally learned how to spell? Yeah.
Well, that's why SCAPE never made any sense to me, because in Australia it would be SCAPO. So it's the main reason I don't like SCAPE, because we have to spell it differently in Australia. SCAPO doesn't sound as scary as SCAPE. Anyway, so essentially what these researchers did is it's actually 2 experiments done in a laboratory with dead pig esophagus, esophagi or esophaguses. I don't know.
I would think esophagi, but I am not a Latin, or I don't know if even Greek or Latin. I'm no specialist in dead languages of any sort.
Okay, good. Well, you say one and I'll say the other. That way we get a clear pass. Okay, good.
Yeah.
So what they did is they got some pig gullets. One of the experiments, they opened it up so the mucosa was exposed. They put a button battery on it, and then they let it run basically for a couple of hours, and they measured what happened to the pH of the surface of the mucosa. They measured how much the voltage of the battery discharged, which is, I think that's a great metric. Like, can you still use the battery after your kids ingested it? Like, that's something I really want to know. Can I put it back into my TV remote at the end of this experiment?
They have a nice supply for all of their clocks and, key fobs and everything like that. I assume that's what's keeping them in business.
They also looked at how much the sort of macroscopic surface area of the mucosa was damaged around the button. And then they sent it off to the lab to get some poor pathologist to look at it under a microscope. And it was an unblinded pathologist, which, looking down a microscope, clearly you don't want to be blinded, but he was unblinded as to whether or not the button battery, what substance was applied to it subsequently, which kind of defeats the point of the experiment, which is a bit odd. So, and then the other experiment, they basically left the esophagus intact and then stuffed the button battery down to the middle of it. And then they applied a whole heap of different solutions to see which one neutralized the button battery effect. And the things that they used were saline as their control. They used honey, jam, Coca-Cola, juice, milk, yogurt, and a couple of different brands of each of some of those products, which is interesting because I wouldn't have thought there would be a big variation, but hey, there is. And the bottom line is that if you are trying to neutralize button battery burns in a pig's esophagus on a lab benchtop, you should probably use honey or jam. But the others didn't seem to make too much difference. So are these really numbers that we care about? Is this something that we really want to do differently? I don't know. And as you pointed out in your write-up, is the fact that this is just a thick liquid around it that's making the difference, and would that convert over into an in vivo experiment? I had a chat to my son Julius, who is a professional apiarist. Atheist? No, he's an apiarist. He is actually an atheist and an apiarist. He's a beekeeper that doesn't believe in God, and he is very good at dealing with honey and harvesting honey. And he tells me that on a 37-degree day when we're harvesting the honey, it's very runny. And on a cold winter's day, it's very gluggy and it takes a long time to pour. So, maybe it does make a big difference.
Very good. That's an important insight. Yeah. So it's not going to stay in the esophagus for very, very long. No, I had not considered that at all.
It's like liquid water at that temperature. So, go for it. The reason that they did this trial was because I think it was the European guidelines that basically said that if your child ingests a button battery and you think it's stuck in their esophagus and you're on your way to the emergency department, you can give them honey or jam every 10 minutes until you get to treatment, which seems like a pretty low-risk thing to do if the child's just swallowed a battery. And it's probably, do you need a spoonful of sugar to help the honey go down? I probably don't think you do. It probably goes down pretty well, to be honest. So, Justin, are you going to change your button battery formula? What do you do in your ED? And is this a protocol that you're going to follow?
Yeah, so surprisingly, because this is atrocious evidence on the scale of things, this is actually probably practice changing for me, but mostly because, so this has been recommended in a lot of places for a long time, and it's always made me very nervous. For one primary reason is this is a dangerous condition with really bad outcomes sometimes, and I worry that the sense that we have a temporizing measure can delay the definitive management. It might be like, we see this all the time with the esophageal food impaction, which is not that big a deal, but like, we'll just leave them for another 4 hours or 6 hours. You can try the glucagon first. You can try the Coke first. All the things that we've already talked about that don't work. And so it's made me very nervous when it seems like there's a medical management and you're trying to get somebody up out of their bed in the middle of the night. The delay tactic has been a concern. And so I have used the lack of evidence to say, hey, we probably just shouldn't be doing this. Let's just get them to the definitive care. That still might be the answer. And I'm not sure that dead pork esophagi are the definitive answer, but I actually hadn't realized. I always sort of thought that it was an electrical injury, and I guess it makes sense. The whole way that acids and bases work is essentially electricity and breaking off those extra electrons and things like that. But I hadn't really thought of these as alkali injuries, which we know are sort of the worst possible injuries that you can. And so seeing a pH go down from the 12, which is we know does significant damage, to 6, 7 or 6 neutralized essentially with the honey and the jam, but not with anything else, is at least a strong physiologic reason. And I only work in places where this scope is not going to be done in my hospital. So there is going to be an hour transfer no matter what. Again, I would strongly emphasize that I worry that you should not delay the transfer. You should not delay the phone call. This is not a thing. But am I going to have the kid drinking some honey during the ambulance ride on the way down if they can tolerate it? I think this is probably enough to say that that's not an unreasonable thing. Well, hopefully we get some. I mean, I don't know that this is ever going to be really well done in an RCT, but it's not that hard. There's enough of these kids that are being transferred that we honestly should be able to see outcomes with a pretty small number of kids. If the outcomes are as dramatic as they're showing in these photos. So hopefully somebody can organize an RCT, but I think it's enough to say, yeah, sure, give some honey if you can find it. I don't delay the ambulance leaving because you're searching the hospital trying to find some bloody honey though, right? That's the concern. Don't cause harm because of bad levels of evidence.
That seems very fair. And like you say, this is great in vitro study, but we do need to convert it to in vivo. And like you say, at the end of the day, I was listening to the EM Cases podcast recently, and they had a pediatric toxicologist on there talking about this very issue, and they were saying you could use sucralfate and other drugs as well to try and neutralize these button batteries. But this just seems a lot easier than getting a kid to swallow sucralfate, which probably tastes pretty nasty, I'm guessing. So honey seems like an easy thing to do. And at the end of the day, this would not be a hard trial to do because you can just look at endoscopic outcomes and what actually happens to kids. And it'd take a while to get the numbers, but this is something that there's pretty big databases around the world already because this is a pretty hot topic in pediatrics at the moment.
Hopefully we'll see better data at some point, but yeah, at this point, as long as you're on the phone with your endoscopist, there's no harm in honey, jam, sucralfate, whatever you want to do.
Cool. All right. Let's move on to the next one. A bit of a myth-busting paper. I really like this paper. So this one's all about the myths and misconceptions around the treatment of hyperkalemia in the emergency department. The title of the paper is Dispelling Myths and Misconceptions about the Treatment of Acute Hyperkalemia. I feel like I just said that in the American Medical Journal. This is from 2022. This is a really nice, neat, well laid out paper. I really like the way they've structured this, where they've said, here are 4 myths, and then they've gone through and done a really nice sort of broad sweep of all the evidence and just outlined some really pragmatic approaches to things. So really good paper. If you're going to read any paper and something you might want to leave on the flight deck at your hospital so that everyone else can have a read it as well, it's very digestible as opposed to the previous paper. Which anyway, the 4 myths, and I'll let you go through them one at a time, Justin, but number 1 is that Kayexalate, or what we call in Australia Resonium, is pretty much a pointless drug to use in the emergency department. Number 2 is that you shouldn't give lactated ringers or Hartmann's or CSL or whatever you like to call it in your part of the world to people with hyperkalemia. Number 3 is that ECG is useful in predicting hyperkalemia. And number 4 is that everyone needs calcium if they've got hyperkalemia. So, Justin, why are these wrong? Do we believe this paper?
Yeah, I think this is a good paper. I think most of this is old news at this point. Like, I think if we had talked about this paper 5 or 10 years ago at the beginning of our podcast, this would have been potentially more groundbreaking to some people. But I hope everybody's heard of these at this point. And the only one that is a good reminder to me that I think is still leads to discussions is the ECG changes, because that's an easy one to forget. KX-late we've known for a long time. It made it through the market before evidence-based medicine was invented, but there's just no evidence that it helps in the short term, and some reasonable evidence of harm. So there's been 4 RCTs, 3 of them were negative, showing no change in potassium at all. And the only time that you see a change is like a day later. You might see potassium lowered by about 1. So it is not helping the acute setting. And then there's this worry about acute colonic necrosis, and you only have to kill 1 patient with a drug that has no benefit for the harms to outweigh the benefits pretty dramatically.
Yeah, and I will say there that if you've ever had to give an anesthetic to someone who's recently required hyperkalemia treatment, for this is not the patient you want to be giving acute colonic necrosis to, because they're not in a good way generally.
So I still haven't done the evidence review that I want to. There are some newer agents that have replaced KX-late around the world that are supposed to be a little bit safer. But I still think that they're more for chronic management rather than acute, because it's hard to get rid of enough potassium through your GI tract. But maybe one day we'll have a longer conversation about the role of those. I also don't really care that much about lactated ringers. Now, this may be controversial. It is true. There's no way, just physiologically, go back to medical school. If a patient's potassium is 8 and you're worried, giving them a fluid that has a potassium of 4 can't raise it any higher. So you're fine as it is. Like, that just dilutional effect is fine, but also all your potassium is intracellular. So the tiny amount in the little bit of IV fluids is just irrelevant. So we knew that, just basic math, but you can go also through the evidence that they present there. But I also don't really care. I know everybody loves using these quote unquote balanced solutions these days, but saline is perfectly fine. We have massive RCTs showing that it's perfectly fine, even though people like to interpret those the other way. So who cares? I still use saline for almost everything in the first couple hours. But if you want to use anything with a little bit of potassium in it, that's also fine. I don't think it's going to matter at all. So I think the only one that really matters, and there's not great evidence for it, but unfortunately the ECG just can go all over the place. So you got to respect potassium, and particularly acute hyperkalemia. The chronic, there's a lot of patients who live at 6 for forever, and who knows what's going to happen. But I think a lot of us were trained to look first at the ECG. And then if the ECG looked okay, you can just sort of sit back and relax, do your things. But they remind us that you can basically jump. There's not a nice smooth progression from that, peak TEV to some PR prolongation to eventually you get to sine wave to eventually you get to death. That doesn't work like that. You can jump anywhere you want, and you can go straight from a perfectly normal ECG straight into VFib, and that's not something that we want. So these patients warrant respect, even though I think a lot of us can get complacent, right? I learned this with a lot of stress when I was a resident, how to manage acute hyperkalemia, and then you manage 300 or 400 patients, and for the most part, they're perfectly fine. And it's pretty easy to get a little bit complacent as you're slowly shifting them and nothing happens. Just to remember that every once in a while you will jump and go straight into VFib. I think to me that's the nicest reminder. Cardiac monitor, pay close attention. I think most of us are doing that, but it's easy to be reassured by a perfectly normal ECG, I think. And then the final one, I'm not sure how people are going to feel about it, but you don't need to give, they sort of conflict. Myth 3 and myth 4 seem to almost conflict. They're telling us that you don't need to treat everybody with calcium. Calcium is really for patients who have ECG changes, but they just told us that the ECG changes don't mean all that much. Now, the calcium is specifically to stabilize. I never really knew what this means. We can get a physiologist to tell me exactly what it means to stabilize the cardiac membrane. That would be wonderful. I don't know. But the ECG changes are a marker of something is now affecting the heart, and that's where calcium comes in. And they suggest there are some potential harms, but mostly it's going to be like some local extravasation and necrosis if you give everybody IV calcium. So you might want to be a little bit more stingy with that and wait until you see at least a peak T wave or something like that. I don't know. I thought it was a nice paper for people to just review. If any of those myths are something that you still believed, go ahead and read the paper for full details. But to me, just a nice reminder, and I like anything with the title myth in it, so it gets into our podcast.
There you go. Yeah, I think the ECG thing's interesting, and I think that we've sort of shot ourselves in the foot a little bit with the FOMED community, because everyone loves putting up these ECGs on Twitter or whatever that show, the effects of hyperkalemia and what it does, and you pick this ECG and can you see the U waves for whatever low potassium, and we love that. But if you really want to know what someone's potassium is, you should do a blood test. Don't do an ECG, because that's going to tell you what it is. And I think it's a very simple point, but I think that we sort of sometimes think we're smarter than we really are, and we can't pick these things. The sensitivity of an ECG for detecting hyperkalemia was somewhere between 20 and 50%, depending on which paper you read. So it's actually it's even worse than a coin toss in terms of if you want to pick it. And the specificity was much better, but we sort of know that if someone's got weird-looking ECGs, then... But unfortunately, most of the renal patients that I deal with, they already have wildly abnormal ECGs because of their 3 heart attacks and, multiple ablations for their AF and all that sort of stuff. So the ECG is just not useful. If you really want to know, get a blood test, do a gas, see what's going on. Don't rely on the ECG. My only other point was around the calcium. Certainly there are harms. We've actually removed calcium chloride from our ED, so pretty much it's impossible to get. So we only really use calcium gluconate because it's much easier on the veins and it doesn't get activated until it's been through your liver. So it's much safer drug to use in that sense. It's still giving someone calcium. There's not a lot of downside to it, but I think if you're using calcium gluconate, you're not going to get into too much trouble. Just got to recognize you need to give a bit more than you might have otherwise. But hey, crack another ampule. It's not that tricky to do.
Yeah, I can't remember the last time I wrote for calcium chloride, mostly because in this era, I don't see much need for central lines. So yeah, I use calcium gluconate all the time as well, in which case maybe that's partly why I was not that excited about these myths, because even if there's not an ECG change, I'm not sure that 1 or 2 amps of calcium gluconate's really going to be all that harmful. And because the ECG changes can happen whenever, and all of our emergency departments are so busy that I'm not sure that we're going to catch this early subtle changes on an ECG. In an ideal world, absolutely, you're going to have a nurse at the bedside. You're going to have, cardiac monitoring. You're going to see all this stuff. In the real world, I'm a little bit liberal with the calcium because, you just don't know when the patient's actually going to get rechecked next.
Yeah, that's fair. Can I ask you a question too? Like, I think I see a warped perspective on hyperkalemia and renal failure, because, like, I see some patients with spectacularly bad potassiums who haven't had their dialysis for 3 weeks sometimes at a time because they've got other priorities in life. And these patients seem to do fine with potassiums of 8, 9, 9.5, 10, and their ECGs look fine. Do you think that that's a chronicity problem? Like if you constantly live at those really high levels that you just don't get the changes, and it's really that rate of change problem? Or is this just some other physiology going? Is it to do with the acid-base balance because they're also very acidotic that they're behaving that way? I don't quite understand it. Maybe a really smart nephrologist can tell me.
Yeah, or there's the guy who does the great physiology Twitter tutorials that I'm forgetting the name of him right now, who might be better at answering than me. But yeah, my understanding has always been it's been chronicity. Basically all the electrolytes, right? The brain changes in sodium, everything else. Your body seems to be able to adjust very, very well. And that makes sense. Sure. If we're talking about, and I'm not sure the mechanism, this would be great. I might go down a Wikipedia rabbit hole after I let you go to sleep tonight. But you can imagine the whole point is it's not the absolute potassium that matters. It's the gradient across the cell wall. So all you need to do is, if the potassium's a little bit higher extracellularly, you need it to be a little bit higher intracellularly, or you need a different electrolyte that is higher. So it makes sense to me that the body could adjust when it's up for weeks and weeks and weeks and months, and just not so at all when it's for hours.
Yep, sounds good. I'm pretty sure that calcium thing is something to do with the triggering of the action potential threshold, but that could just be words coming out of my mouth.
The nice phase 4 action potential in the heart, or something like that. Yeah, it's good. I know all about depolarization for sure. It's necessary for an emergency physician.
Well, to pass the first part exams, it is. But after that, you can just forget about it. Hey, I never sat them, so what do I know? All right. Let's move on to another trial of dubious significance. Do you want to do the intro on this one? Tell me what you think about this.
I think I would have skipped this paper 100%. I think this is actually very, very silly, but I love it because some people really find this concept interesting. So this was sent to me and our buddy Anton Hellman and requested specifically an EM quick hit because a number of people had asked him about this paper. And so it gets included. So to back up, what are we talking about? This is a non-inferiority randomized control trial comparing nebulized ketamine to intravenous morphine for older adults in the emergency department with acute MSK pain. And so, I mean, to some degree, rightly so, we are now aware of the many harms that can come along with opioid use. Although I think we'll talk about this, but I think we've probably gone too far when we're talking about elderly patients with severe pain in the emergency department for one-time doses, but we can come back to that. But people are concerned that there are harms from opioids, and so we've been looking for alternatives. And for some reason, people have become very attached to ketamine. And don't get me wrong, I love ketamine. Give me an RSI, give me a good procedural sedation, even give me long-term pain control in a trauma patient I have to send down to a trauma center. Ketamine is like the best possible option. I'm not sure about the depression and suicidal ideation yet. We'll come back. Ketamine's used in a lot of places. But one-time pain control never made a lot of sense to me. Unless it truly is something that their pain is going to be gone in 6 hours, I can fix it. I can put their shoulder back in or whatever. But this is an elderly patient with pain control, and their whole logic is, these patients are going to have lots of pain for longer than a younger patient. So I can treat their pain with ketamine for an hour in the emergency department, but what the hell am I sending them home on? It doesn't make any sense. Anyway, their logic is opioids bad. Let's use something else. And in this trial, I guess because they don't want to start an IV, they decided let's try to nebulize that ketamine. And so they compared a standard dose of morphine, 0.1 milligrams per kilogram. We know that treats about half of people's pains, but in the elderly, it's a reasonable dose of morphine. And they compared it to 0.75 milligrams per kilogram of nebulized ketamine. And I think they tell you that you get about half of that when you nebulize it systemically, estimate. So this is your standard, 0.3 milligrams per kilogram pain dose of ketamine. And in the end, they basically say the outcomes are the same. I think they said it was non-inferior to morphine using, I'm not going to do my full non-inferiority rant right now, but basically it could be up to 1.3 points on a 10-minute scale worse than morphine. We'll leave it. We'll leave it at that. I think that's not the question. I don't think you need to understand the stats of a non-inferiority trial to do this. I think you just have to ask yourself, what is the real benefit of using ketamine over morphine in this situation? I'm just not sure that I see it.
Yeah, I completely agree. And the whole non-inferiority thing is fascinating in that, well, if you look at the actual pain score reduction, it was 2 out of 10, so 20. They're going down 20%, and the non-inferiority margin was 1.3, which is pretty much all of that. So it's a pointless non-inferiority target, really. And a better thing to base this trial on would have been the patient satisfaction, or what their actual plan, what patient-oriented outcomes were, because that's probably more important. And it's a tricky one. Like for MSK pain, if I'm pretty convinced that I think that someone's got musculoskeletal pain, I pretty much never prescribe opiates. Like it's very rare that I prescribe opiates. If someone's fallen down, they've got traumatic pain, sure, that's fine. But if it's chronic back pain or a flare of chronic back pain, I'm not reaching for opiates. I'm definitely not reaching for ketamine. There are a few longer sort of take-home options becoming available with ketamine in the pain community, at least here in Australia. I don't know about overseas, but you can get lozenges and you can get different sorts of ketamine applications nowadays, which you can sort of use as an outpatient. It would certainly make the nursing home a more fun place, I think, if everyone was completely in the K-hole. That would just it'd lift the spirits, but I'm not sure if that's something that this paper was measuring. But it seemed like an odd choice for MSK pain. And if I was going to pick a group and I was specifically looking at older people, I'd probably look at something like NOFs or surgical neck of humerus fractures or something else. Like just pick one group that are going to have acute pain that, yes, you can fix today or tomorrow. It's going to get better in a week. But just taking all these punters seems like a very strange and unusual thing to do. So yeah, I can't see myself nebulizing it. I also don't quite understand why they use nebulized ketamine and not just go for a small IV bolus. You've already got a drip in the patient. You're going to give them IV morphine. I don't understand why you need to use nebulized ketamine. Like it just seems like a very random way of dosing ketamine into a person, like if they're in the ED.
Yeah, I mean, I guess in the long run, outside of a trial, they would tell you they're not going to put it in an IV, and so you're trying to avoid that. And then, unfortunately, one of the reasons I still use morphine in a lot of situations is just give them a tablet. It'll take a slightly bit longer time to go, and unfortunately, we just can't do that with ketamine. And so you end up doing all these bizarre things like intranasal and nebulized. And this has got to be better than intranasal, I guess. And so maybe in the kids where people love this intranasal route, even though it causes all sorts of pain, and every kid I've ever done intranasal on screams like bloody hell. Maybe if you can nebulize a few of these things in that kid, you've got to get the X-ray and it's still too much pain, and you want to get them feeling a little bit better before you start an IV. Like in pediatrics, I could potentially see a benefit short term, but it's because I think you have to delineate. Am I trying to treat a short-term problem or a long-term problem? And I just don't see ketamine as a great option for long-term pain control. It doesn't make a lot of sense. Yeah, if I have a kid comes in, it has a deformed wrist, and I still need to get the X-ray done on it, I can start an IV because I am going to start an IV at some point, but kids don't like that either. So I could see a role for nebulized ketamine in that situation, although kids don't like any medical intervention, and it's the scary, noisy nebulizer also scares the hell out of them. So I'm not saying that there's no role, and if listeners have great ideas for this, sure, send them into us, and it does seem to work. If it's potentially as good as an IV morphine, it does seem like it's going to do something for pain control, but yeah, 2 hours later, I still have to send this patient home on something. And to me, especially in the elderly population, if they were in enough pain to potentially need an opioid, I want to know how they're going to respond to that. Some patients just don't stop vomiting at all when I prescribe them morphine. Some people start hallucinating. Why not have that happen right off the bat in the emergency department so you know that it's a bad idea to send them home? Or if you're still somebody, and I really hope you aren't, but if you're still somebody who uses stuff like codeine, you want to know if your patient's a responder or not, right? Because a bunch of people don't have the genetics. So at least see if the prescription that you're going to give them works. Try it in the emergency department. Don't start with ketamine and then send them home on something completely different is my take. So I see zero role for nebulized ketamine in this population. Maybe it'll come up one time in my career where it'll be a good idea in somebody who I don't want to start an IV. I don't know.
Fair enough. Okay, so I think we can all agree that both of us say that this is not a practice changer, and I know that if I did write up nebulized ketamine in my ED tomorrow, I'd get a lot of raised eyebrows, and rightly so, because it seems like a bonkers thing to do at this point in history. And these non-inferiority trials should not be changing our practice because they don't really tell us what we really want to know, which is what actually happens to patients. So good on. Let's move on to another trial then. So this is a really well done trial. So I'll do the intro, Justin. So this is association of small adult ventilation bags with return of spontaneous circulation in out-of-hospital cardiac arrest. And this was published in Resuscitation December just gone. And so this is a really interesting paper because it's one of those things that's really difficult to study because you're dealing with a really dynamic situation where you've got paramedics on the side of the road doing resuscitation. And there's been a bit of an idea for a while that if we give them too much ventilation, patients that are dead or requiring cardiopulmonary resuscitation, if you use too much bagging, you blow too much air, too much intrathoracic pressure, it's going to somehow impede their return of spontaneous circulation. You're going to get worse outcomes. That was sort of the belief that most of us held, I think, before this trial came out anyway. So this is an interesting trial. This is a before and after trial, essentially. So the Seattle paramedic EMS fire department changed in 2017 from a standard size ambu bag, which is 1,500 mils, to a smaller bag, which was 1,000 mils in volume. So they were getting smaller volumes and much more physiological volumes, sort of 450 to 500 mils, which is sort of what most standard adults would normally need. And we all sort of expected that using a smaller bag would lead to better outcomes. But Justin, I won't do give away the bottom line, but essentially it didn't. What happened?
Yeah, so exactly the opposite of what we would have thought, which is interesting. I saw this shared around a bit, and I honestly, before I read the paper, I thought the smaller bags had improved outcomes, and then it was going to be a question of whether a before and after study is good enough design. But actually, the smaller BVM was associated with lower rates of ROSC. 33% versus 40%, statistically significant. Less people came back using this smaller bag. it doesn't make a lot of sense to me. It also doesn't make a lot of sense because in general, the bias in before and after studies is people have tended to get better at resuscitation over time. And so outcomes generally in the after group are better to begin with. And so the fact that they're getting worse is much more shocking and probably more believable than if they were getting better, because almost always before and after studies show that things get better, which is really interesting. So I don't know, like to me, the argument for using lower respiratory rates and lower volumes makes tons of physiologic sense, and I'm not sure that I have a good explanation for this. If it had been a dead neutral trial, it would make sense to me, because honestly, if you look at their outcomes, their end tidal CO2 between the groups are basically the same. Their respiratory rates are basically the same. So they probably in this group have been trained so well. This is Seattle Fire, which is like they're the ones who pushed almost all of our CPR research for the longest period of time. And so I can imagine they're better trained than most people at how to do respirations. And so in their hands, maybe it just doesn't matter what size bag you're using. And that might be what this data is showing, but it doesn't explain lower rates of ROSC to me. The only other comment that I would make in terms of how we take this is only in patients who have an advanced airway, which is interesting. But if I was doing this research, I think that's an incorrect research decision, because if you're going to make this decision for all of your EMS and you're going to change from a big bag to a small bag, you're using that on all patients. So we sort of need to know the outcomes in all patients, not just those that you intubate. And maybe it's harder, or maybe it's easier to do a standard bag valve mask with a smaller bag. I don't know. But honestly, that's the group that I think is more likely to see a difference than somebody who has a tube, because who cares? You can get air in and out of them almost no matter what. It's a much bigger skill to get air moving in and out when you're just holding a bag valve mask seal. And I can imagine, I see a lot of paramedics, where you're doing the under the arm squeeze thing, and you sort of need the big bag if you're trying to do this by yourself, or you're doing a two hand seal and you're squeezing the bag with your arm, and that might be harder with a smaller bag. So I think that was a poor research decision by not including everybody and only including advanced airway, but it definitely does not support a change to a smaller bag. I don't know if it supports changing our teaching. I'm interested to hear your anesthetics and emerge brain comment on that, whether we've been teaching it all wrong all these years.
No, I don't think so. I think I like your point about the closed airway circuit versus just using a mask bag situation, because I think from an anesthetic sort of point of view, you can certainly do a lot more harm with a bigger bag. So, like if you're thinking about the downsides, then the bigger bag you'd think would be more likely to, and unless there's that sort of paradoxical effect, whereas if you've got a smaller bag, because you think you're going to do less harm, you just squeeze it a lot harder, so you're actually generating bigger pressures. It's really hard, and this data can't really tell us this. From memory, looking through this trial, the number that you'd really want to know was what happened to the carbon dioxide. So they had really good granular data on these patients where they were actually measuring the end tidal CO2 at the roadside, which is just amazing. I think that's really cool that they do that. And the mean end tidal CO2s at the ends were a little bit different, but not to the point where it would change your physiology. Like they were 4 or 5 points different between the two groups if you averaged it overall. So that doesn't really explain it either. It's not like one group was getting hyperventilated a lot more than the other. My guess is that in resuscitation, where patients are actually receiving CPR, it's not so much the ventilation, but the intrathoracic pressure that's the problem, and that's probably really hard to measure. But once again, you'd expect that big bags would give you more problems with that, not small bags. So it's paradoxical. So it's a fascinating paper to read, and sort of flies in the face of what I sort of anticipated as well. So is it going to change what we do? I think it's a bit like the old fluid paradox. Like, it doesn't really matter what you do, just do it carefully. So if you're bagging patients, just make sure that you go at that nice steady rate and coordinate it with your resuscitation partner. But I don't know that this trial can tell us what the right answer is. It probably just tells us, if anything, that we don't know what the right ventilation is in resuscitation. And I think whenever I'm on the courses where we're teaching this stuff and learning about, there's always some very dogmatic numbers that get thrown around about the ratios and how much you should do. And, oh yes, we've got a closed circuit, so now we can do this and you don't have to coordinate it. But I don't think it really matters as much as we actually think it does in our teaching. I think it's more about CPR and shocking, as we know. So is this going to make a big difference? Probably not, but it might make me a bit looser in what I teach, or what I tell people is acceptable in a resus. Like, just don't go crazy. Just do a sensible amount of bagging, I think, is all we know at the moment.
Yeah, I'm still a fairly big believer, especially in adults, that the ventilation part probably doesn't matter at all in the first 8-10 minutes of cardiac arrest. An open airway probably does, but I imagine just pushing on the chest, you're moving the chest more than I move through normal breathing, and that probably takes care of most of our ventilation needs all by themselves. And you can just see that, right? If you have an LMA in, which is what I use instead of an endotracheal tube, and have and tidal on the end of that, you can see the breaths, and they're as big as the patient. I'm waiting for procedural sedation. It's the exact same waveform, more rapid because of the degree of CPR. So eventually this matters, but I think this matters a lot more for in the period of ROSC. If you're going to save somebody, it comes down to those first 8 minutes, and the ventilation part probably is not the big decider. But again, this data tells us something's going on here, or there's some other bias. The other thing I think we need to point out is it may be completely unrelated to these bags, and this may just be a scientific bias. This comes up all the time in studies. I'm not sure what it is, but there may be some confounder that I have not thought of, and the authors don't give me a good hint to that explains all this difference that is not the bags themselves.
Yep. And like I say, ROSC is also not necessarily the outcome that we're after with all these resus trials. It's more about neurologically intact survival, and I'd be surprised if this made any difference. I don't think we can say from this particular trial, but they had pretty good numbers. They had nearly 2,000 patients, I think, that they compared. So it's a really well done large resus trial. So fascinating.
More for the larger conversation. Yeah, unfortunately it failed, but I think there is a more interesting overlay conversation here, which is we spent a decade teaching people to ventilate less, and these guys eventually said, forget it. We can't teach them. Let's do a systems or design change. And that to me is a really interesting approach. And I wish it had succeeded because I like that kind of thinking. But I think it's the kind of thinking that we need to take more seriously more often in medicine. Our go-to all the time is education. Pick anything, whatever. I go back to infectious control. Whenever there's a hand washing audit and there's not enough, what do? They try to educate with posters. And does it fail every time? Of course it fails every time because that's not the problem. But if you just put hand washing stations that are full somewhere where I can access them, of course I want to wash my hands because everything is dirty and disgusting. So these small interventions, like this seems really small, but I think these small interventions are the way to push practice change. But unfortunately, it is a multi-tier process where the practice change actually needs to be beneficial. And then you also need to get clinicians to change practice. So it's complicated, but I like the underlying philosophy of, look, if we think wholesale change is necessary, then the easiest way to do that is with design solutions. So easy examples, right? I think over the 10 years that I've been doing this, we've moved away. People aren't doing needle crikes anymore. We think that it's a good idea is scalpel finger bougie. And so good departments now just have a bag that has a scalpel finger bougie. And if it's the easiest equipment for somebody to find, it's what they're going to use. And I think design changes like that make it so that it's the first equipment somebody can find, and that's the equipment they're going to use. Education doesn't matter at that point. You're just going to use whatever's in front of you in the moment. So I think that's a more interesting overall systems discussion to have out of this. If you want to see change happen in your department, my guess is the worst approach is an educational campaign, which is funny as we're talking on an educational podcast. And the best approach is something much more upfront and design-based.
I got to say, the thing that I take away from all of that is you have fingers in your bag and your scalpel finger bougie.
Just in case you don't have enough.
All right. Let's move on.
High quality medical education. Basically, if you listen this long, I'm telling you, it was a waste of your time and your effort. Go do something else.
All right. Now, this next paper, we'll move right along. Justin, I was looking back through my emails when you sent me this paper, and it's actually 10 years ago exactly that I first emailed one of our administrators about this exact problem. So this is 10 years that I've been ranting about this, and yet another paper that says I told you so, pretty much. So what are we talking about? So we're talking about the peripheral administration of norepinephrine, a prospective observational study in chest in August 2023. So just to lay out the background, when I trained in anesthesia school, you were not allowed to give adrenaline or noradrenaline or dobutamine or any of those vasopressors through anything other than a well-placed central line, and if you try to put it peripherally, you'd get slapped over the wrist and told that you're some sort of heathen. And of course, we know that is untrue because we've had multiple trials showing the safety of this and the effectiveness of it. And so this paper was really interesting in that they have done yet another 600 patients in a single center ICU who they've given peripheral IV noradrenaline to, and the outcomes they're looking at here is once again the safety data, looking at extravasation and what actually happens. And the long and the short story is that it will extravasate from time to time. I think they had 35 out of their 600, so about nearly 4% of them had some sort of extravasation event happen. And the bottom line is that basically no harm came to any of these patients, and so they did just fine. And there was only one patient that had any sort of skin changes, and they were pretty sick by the sounds of it, in that they died shortly thereafter anyway. So this is just adding more fuel to the fire, basically saying if you're not doing this already, then you should probably be doing this in your ED or in your ICU. It's not really an ED problem, because I think if the patient's in the ED for longer than 24 hours, you probably have bigger fish to fry than deciding whether who puts the central lines in. But essentially what it showed was that for every patient you put a peripheral IV in, you save them about 1 day of a central line use, and about half of the patients didn't need a central line whatsoever. So you've saved some sticks in the neck or the groin, which, depending on where you work, can be a really important thing. And this is why I became quite passionate about this 10 years ago, because placing a central line in a big, shiny tertiary hospital, ED or ICU, is no biggie. We do that two or three times a day sometimes. But if you're working in a small peripheral hospital and you haven't put a central line in for 10 years, probably not the right time to start trying. So this was why we thought that this data was really good, because it proved the safety of something which was a lot safer than the alternative back in the day. So we've been doing this for years now. Is this a thing in Canada?
Yes, I think it's the latter point that you made, which is more important, which is why I included this paper. Because at this point, we've talked about at least this 5 times, I think, in the time we've been doing this podcast. I think we know the safety of this. Yes, there's a small risk of extravasation, and a very, very, very small to almost non-existent risk of something actually bad happening from that extravasation, some necrosis or whatever. So if it was just another paper looking at safety, I wouldn't care. But just like we talked about with our very first paper, maybe our second paper, the MRSA paper, we tend to have these conversations from a very one-sided perspective. So in this case, we spent a lot of time talking about the potential harms, but almost no time talking about the potential benefits. And I really love this paper for highlighting that. Using peripheral pressors is not only safe, but half of patients didn't need a central line. That's a huge benefit that people aren't talking about. Like, look, central lines in and of themselves aren't that dangerous. We shouldn't freak out about it. It is a procedure that we should go. Unfortunately, one of the things, because of this, I almost never put in central lines anymore, even though I love procedures, because it's just not great for patients. It's much better to see, do they really need it in 12 to 24 hours, rather than the guy who's seeing you in the first hour jumping straight in and being a cowboy. So my skills are deteriorating over a decade because it's just not necessary of me anymore. But I think for patients, that's really, really good news. And so I like this paper for highlighting that. The use of peripheral pressors is not only safe, it likely saves your patients a potential invasive, or it has a 50% chance of saving your patient an invasive procedure with no harms. That is a good addition to the literature when you're making these kind of decisions.
Yeah, I had a just quick read through the protocol, and there's a couple of things that jumped out at me as a little bit odd about this paper compared to some of the other peripheral vasopressor protocols and papers we've read. And they sort of changed their protocol over the course of this study, in that they initially started out with you had to have drips sort of in the forearm. They couldn't be in the wrist or in the hand, and they couldn't be up higher. And they actually used really small cannulas. So they were, I think on the original protocol, they were 22s and 20s that they were using, which is, to my mind, pretty small. And maybe you know the answer to this, Justin, but my general feeling is if you're putting in a really small cannula, like a little blue 22 gauge, I just feel nervous about that. I would much rather have a more generous and a longer catheter in a juicier proximal vein, because the real harm, I think, in using peripheral vasopressors is not from the extravasation, and it's not even so much that, but it's when they suddenly stop working in the middle of the night and you're off doing something else and the nurse doesn't notice it for half an hour, and they keep up titrating the noradrenaline while it's slowly dripping into the skin, and it takes a little while for the penny to drop because the blood pressure is not coming up and the patient's left hypotensive for an hour. That's the real harm for me in this. And so I think it's not such an ED problem, because if I'm standing in the next cubicle and I notice the blood pressure dropping, then you just go and look at the drip. But I usually say we want to have a really good drip and a really good vein to do this protocol. And I think if you did that, you'd probably almost have zero extravasation events, and you'd miss that unpleasant moment when you've been fiddling with the blood pressure and titrating and flushing the art line repeatedly, going, this bloody blood art line's not working. And all of a sudden you realize it's because the drug's not actually going into the patient, and that's the problem. So I think that's the real risk. And I didn't like their protocol that they started with, but towards the end they had a better protocol, I thought.
So yeah, I think people get this wrong a lot, and I've argued very strongly about this before, and I think people conflate two different things. So I like the way you phrased it, a good drip in a good vein. I think that's the important thing, but people took from the early studies that means that you have to have at a certain height, everybody's like antecubital fossa or higher in a certain size, and unfortunately all of those are just bad confounding based on bad data. So in previous studies, there was a higher rate of extravasation or more extravasation in absolute numbers happened down near the wrist or hand. But that's just because that's where we put in all of our IVs. And so the higher numbers is just confounding, I think. I think it's a mistake to focus on the size of the IV by itself. But you point out a very important confounder. If you already tried 3 IVs and the only one you could get was the smallest one in the pinky finger, there's a reason not to trust the small IV. To me, this is a much more again, I worry about people making protocols based on the size of the IV or exactly where it is in the arm, because that's not what matters. I don't care how big the IV is. If you backwalled the vein 3 times and then eventually got it, that is not a good IV. So to me, the key is good communication with whoever actually put in the IV. And we got to get over our egos. Some nurses are really good, or some nurses are not, because some nurses want to tell you that of course they got the IV on the first time and you can sort of see it where you're going. But just, was it easy? Did you backwall it? Did it slide in? Are we confident in that IV? Those are the questions that we just need to have good basic communication about. And I'm less worried about the numbers and location. I want the length is maybe a different thing that is worth discussing. The risk and whether you're close to a joint and whether that IV is likely to move and fall out of the joint. Like, I like mid forearm IVs way more than I like anything close to the wrist or the antecubital fossa, because you're just not going to be moving it nearly as much. So there's a lot of discussions that go into it, but I just want an IV that I trust. But I mostly go based on a nurse that I trust's gut instinct. Did that go in on first pass? Was it easy? Is that a good IV? Much more than I care about the actual size.
I'm even more paranoid than you. I like to put the drips in myself if I'm going to be doing this. But the one thing I do find is that
in North America, that's a very Australian thing. Nurses do IVs here, which made me a very bad doctor when I came down to Australia and New Zealand. What do you mean you don't know how to do an IV?
But I think if you're the patient and you're going to have a drip in an arm and it has to be running 24/7 for a whole day, and the nurse is going to tell you off every time the machine goes bing, bing, because you've bent your wrist or you've cocked your elbow, it's just much nicer to put it in, like you say, in the mid forearm or above the antecubital fossa, so the patient can scratch their backside and feed themselves their hospital food, because it's just unpleasant if you have to lay dead still. And I actually went for an MRI the other day, Justin, because I'm getting old and probably should slow down my sport. But have you ever tried laying dead still, not moving a limb for 20 minutes? It's actually really hard to do. And I was thinking about, how do we do this to patients where we say, oh no, don't bend that arm? Because if you tell someone not to do something, like it's almost impossible not to do it after 20 minutes. It's really, really hard to do. I challenge any of the listeners out there to lay dead still and just recite over in their head for 20 minutes. Don't move your left arm. Don't move your left arm, because it's almost impossible to do. All right, enough of my ranting. Let's move on. Should we talk about ethics?
I'll tell you about this paper. Casey, if there's any hate mail, it all goes to Casey. This paper Casey chose for us is entitled, Is Pregnancy a Disease? A Normative Approach. So Casey really wants to tell us all that pregnancy might be a disease. And Casey, I'll let you tell everybody why. Why would you even say that? I don't understand. No, for real, I grabbed this paper. I can't remember where I saw it the first time, mostly because that is a very provocative title. Like, who the hell would even say that? Is pregnancy a disease? And initially, I thought I was reading it as a joke, but it's really hard to counter their arguments. And I'm not going to be able to reproduce them well here. The paper starts by comparing pregnancy to measles. And, both are self-limiting conditions. Both have a very predictable trajectory that like 99% of the time results in full recovery. Both have a variety of physiologic changes that impair or have the potential to impair your functional ability, and both have a risk of really bad outcomes, including dying. And so the authors point out, what is the difference? And then they go through some philosophy, and there's a number of approaches to this. Most of it's based around subjective criteria about whether the condition is wanted or unwanted. But obviously, that doesn't work great for pregnancy either, because there are unwanted pregnancies, and there's a bunch of overlays to this. Some people are very happy, and some people are not so happy to be pregnant. So I don't think that the reason for including this is, although if you want to, we can definitively try to decide whether pregnancy is a disease here and now and settle it once and for all on the BroomeDocs podcast. But I think if you really took this paper seriously and tried to engage with the arguments, it's really, really hard to come up with a cogent argument to say that pregnancy is not a disease. And that in and of itself is who cares. But I think the point is, defining disease and defining health is really, really, really difficult, and that matters. And I think it really matters as emergency doctors as well. It's something that disability advocates have been talking to us about forever, but especially when we're seeing patients with chronic conditions, it really matters how we approach them. And it's a lot of patients that I see. I walk into the room with sort of this assumption that I would not want to be living the life that they're living, whereas they just that's their life, and they don't see it through the same negative lens, and that can be a bad spot to start a relationship on. I think I just throw it out in that lens. I think it's important to understand that there's a lot. Put it this way: it's important to understand that medicine and the definition of disease is not purely objective. There's definitely a judgment overlay, a subjective overlay on all of these discussions that is, when you dig into it, I think potentially clinically relevant.
Thank you, Justin, for that that explanation. Yeah,
Email to BroomeDocs@gmail.com or whatever.
I can just forward it all right along. So this... I really enjoyed reading this because it challenges what you think, and it really makes you think about how you perceive life and health and what we do in medicine in general. So this was a paper that was written by a couple of Norwegian medical ethicists. Just reading through the paper, you don't know how much of this is sort of culturally normal for Norway, or whether this is just they've taken a really objective ethical stance and they're just sort of trying not to look at anything through any sort of particular lens and just trying to remain super objective. And the way they argue it is there's a lot of different really interesting sort of vignettes and arguments, and they use a few criteria for designing what a disease is that are based off some famous philosophers. So, for example, there was a list of criteria by someone by the name of Rachel Cooper, which said that in order for something to be a disease, the person has to suffer, they have to be very unlucky to have that problem, and it can be treated medically. And you could argue that pregnancy falls into some of those depending on the situation of the person's life. I am going to come out swinging and say completely 100% in my mind, pregnancy is not a disease. And I'll outlay my sort of philosophical ideals around this and ethics is that let's just take a bit of a step back and think of pregnancy. I'd like to think of pregnancy as a phase of life. If you think of it as it's a phase of life that basically is complete necessity, because without pregnancy, you and I wouldn't be here, Justin. We wouldn't be having this conversation right now. And until we're in the cybernetic future where we're all grown in test tubes in a beaker, pregnancy is going to remain a thing for as long as we're alive anyway. So it's evolved multiple times. So sexual reproduction and pregnancy has evolved multiple times throughout history, and it's pretty much how most of life on Earth has happened. So it's hard to say that that is a disease when it's probably the most natural process that can happen to a organism on planet Earth. But if you think about it in terms of it being a phase of life, being a teenager is also a phase of life, Justin. I have 2 teenagers in my house at the moment, and going through puberty is not a disease, although sometimes it does seem like a disease. It is not a disease, it's a normal process. Now, if you get really bad acne and you get big cystic comedones and you get scarring on your face and you really suffer as a result of that, now that's a disease, but it's a consequence of that phase of life. It's not actually, being a teenager is not a disease. All those hormonal shifts are not a disease. That's just the way that our bodies change over time, and it's necessary to get to where we need to be. And then you could also argue that menopause is a disease because people suffer and they go to the doctor and seek treatment for it. But at the end of the day, menopause is just yet another phase of life. And certainly if you get, severe depression as a result of menopause, then there can be troubling symptoms. But I don't think that means that menopause itself is a disease. And aging, is that a disease? Like, we're all getting older every day. I had to go for an MRI, as I just said. Does that mean that I'm diseased just because I'm a little bit older? Like, if you get dementia, then sure, that's a disease. But the actual aging itself is not the disease. It's just that part of life that we inevitably go through. So unless you have a time machine, Justin, pregnancy is not a disease, in my opinion. I think I should have probably been a midwife.
Yeah, I mean, I don't think these authors believe pregnancy is a disease, despite how hard it is to go out. And I obviously completely I agree with you. Although I think the upside of your argument, practical, because I'm not sure that how practical. Like, nobody's treating puberty like a disease, but death would be the other classic phase of life that from that is very negative, and you could see it as a disease. But I think, unfortunately, that's one area that we probably have over medicalized and not just accepted. 100% of people are going to die, and treating death too much like a disease actually has some pretty negative consequences for the healthcare system. I would flip this on its head the other way around. And one of the arguments that they make in this paper is there are some potential major upsides of treating pregnancy like a disease. We have the benefit of coming from industrialized nations with lots of money that goes into pregnancy, and pregnancy is pretty safe. But still, around the world, pregnancy is not safe. And if it was clearly a disease and the medical establishment was clearly involved early, in a lot of places, outcomes could be dramatically better. And so there's some practical upsides from potentially treating pregnancy as a disease. And I think you could extrapolate that elsewhere, right? So your menopause example is an interesting one, but let's just do normal menstruation. Causes a lot of people a lot of distress, but it's clearly natural. It's clearly not a disease. But we know there's not an objective definition of disease or not disease. And I think one thing that people will tell you is things like endometriosis and just basic symptom management for normal menstruation are very under-medicalized in a lot of situations. They're undiagnosed, and I think a lot of women would tell you that we ignore these symptoms or downplay these symptoms. And so sometimes bringing things into the medical fold can bring appropriate attention to them. Now, I think that will scare the hell out of people, because I think bringing normal female function into them and overly medicalizing it could also have tremendous downsides. And I think you just take the common cold. Is it a disease or not a disease? I think everybody's going to say right off the bat, it's a disease, but bringing it too much into the medical fold, there is no treatment for it. And so how many billions of dollars do we waste? How many healthcare systems do we waste for something that has no real bad outcomes? It's a short term. You could claim this is just a natural phase of life. Everybody has to get a common cold here and there. It builds your immunity, and so I think it's really hard to come down really one way or another. And so I think, to me, the real benefit of any of these examples is to say, look, it is not black and white. And the real question that we got to be asking is, are we currently over or under medicalizing that? In other words, are we currently putting the appropriate medical resources or funding towards that condition? And that, to me, is a much better way of phrasing it. So I think that what's fascinating about this paper is you're not going to get a black and white answer for any of these things, disease or not disease. So I think it's a stupid question to ask. It gets to the realm of, does God exist or not? can't answer that question. But are we doing good by dedicating the resources to this particular church or this particular resource? That's actually an answer you can question you can answer. We won't try to tackle that question here on this podcast, but it's something that you can actually practically tackle. And I think, to me, that's the lens that this paper brings.
So that's a very utilitarian response that you've got there, Justin.
I mean, I think utilitarians have some value in life, I think. I don't think anybody pays for this podcast to hear our philosophy, though, but I'm not sure that anybody pays for this podcast, so I'm not sure.
They don't. Though I will tell you that Jeremy Bentham, who was one of the original utilitarians, had his corpse stuffed and stands in a case in one of the universities in England, and every now and then one of the students steals his head and uses it as a soccer ball. So, there's a factoid for you.
That's why I always wanted to be bronzed. I want to be a statue, but yeah, it's hard to take the head off of a bronze statue. That's my goal.
Sweet. All right. Shall we move on to our last paper? A paper in which Justin is going to espouse the virtues of hospital feng shui. And I think possibly the stupidest trial, that certainly in this podcast, possibly one of the sillier trials that we've ever discussed forever, I think. And this is I
love that it's a...
Sorry, I'll do the intro.
Deception trial. It's in the name of the title. It's a randomized deception trial. How can we not include that? And I believe it's another Christmas edition from the BMJ, which is the best. If you're only going to read one journal a year, BMJ Christmas edition is the one to do. But yeah, I'll let you introduce it.
It's cold. Yeah, so this is the effective chair placement on a physician's behaviour and patient satisfaction, a randomised deception trial in the BMJ Christmas edition last year, 2023. And essentially, this is a group of medical students, actually, good on them, who randomised some hospitalist physicians. So these are not emergency doctors. These are hospitalists. So they're doing their ward round on the inpatient unit. And specifically, they couldn't be in a big posse. So they didn't have a gang of like trainees or other things. It was just one hospitalist visiting one patient in a room, which doesn't happen too much in the tertiary centre where I work. It tends to be like 25 people tend to bundle into a room most of the time, which is going to make it hard to get all those chairs in there, Justin. Well, certainly they won't fit in the cupboard.
Is a gang of internists the right? Like, I know that it's a crush of orthopedists and a flow of obstetricians, but I don't know the like group terminologist for a thing. I'm not sure gang sounds right. So I'll let you work on the terminology. Yeah, okay. Anyway.
I'm going with posse. We're going with posse. All right. And essentially for some reason they decided that you could either put the chair right next to the bed where any sensible person who was designing a hospital would put it, or you could lock it in a cupboard. And funnily enough, if the chair was out of eyeshot and you couldn't see it, which is pretty much the standard in most emergency departments where I've ever worked, where it sort of either doesn't exist or it's stuffed behind a curtain somewhere and no one can find it, the doctors use the chair less, and the patients didn't enjoy their interaction with the doctor quite as much. That's the bottom line. Now, we can make this a stupid paper saying, yep, don't lock the chair in the cupboard and everyone will be happy. But there is a deeper implication here for looking at how we design our systems and how we design our hospitals, particularly our emergency departments. So, Justin, tell us about this. Is this going to change your practice, or are you going to carry your own chair with you everywhere you go in your day-to-day work?
I feel like it was a pretty bad show, but a recent show, Jury Duty, where there's like the inventor who invents a chair built into his pants so you can just sit down wherever you go. Yeah, I'm sort of picturing that. So I have like basically a stool sticking out of the back of my pants so I can just sit down wherever I go.
Actually, can I stop you there? I need to stop you there, Justin, because a stool sticking out the back of my pants is going to be the catchphrase for this podcast. Carry on.
Yeah. We'll get on Photoshop, and yeah, this is going to be not the way that I intended it, but that's fine. I can be known as the doc with some stool sticking out the back of his pants. The different stool sample I'm bringing you. I'm down. Yeah. Anyhow, the overall benefit here was not as high as it's seen in other trials, but I do think if I looked at these, I would rather be the doctor sitting than the doctor not sitting in patients' eyes, and I've always known that. But yeah, I've recently switched hospitals, and the newer hospital has way fewer chairs in the rooms, and even when there is a chair, it's almost always occupied by a family member or something like that. So I can't be that doctor sitting, which is a little bit concerning to me. It goes back to our previous discussion with the bag valve masks, but these authors discussed this as a nudge. They were trying to nudge doctors into the right practice. I'm not sure that's the right framing for this. I think almost all doctors these days would rather sit down next to their patients and have a good conversation. So I think it is, you already said, a conversation about hospital design. If this is something we care about in medicine, and it makes sense that we would want to be at eye level with our patients and not hover over them as some all-knowing God physician of the 1950s, then you need to design hospitals in a way that makes that work. And it's just fascinating. So it wasn't for the study. I'm not sure that was clear when you were saying it. Apparently in this hospital, somewhere in the States, I can't remember, I didn't write it down, but
it was in Texas somewhere from memory.
Usual place. Yeah. This, where they store the chairs is in the cupboard. They didn't move it to the cupboard for the sake of the study. That's just where the chair is kept rather than next to the patient bed, which is, I don't know who came up with that idea. Maybe it's easier to mop the floor or something like that. But I think this is a part of a bigger, longer rant for me that we do such a bad job of designing patient rooms in medicine. Things beep in the room, but that's not where nurses sit. Nurses sit out of the room. Like, why, when people are having a good night's sleep, are they designed such that things are beeping in the room? Why don't we design rooms so that patients can have at least a modicum of privacy on their sickest, worst day of their life? Like, I can't remember. I've had not serious hospitalization illnesses, and I don't even want my family in the same room with me when I have bad gastro. I just want to be left alone. Can you imagine being staffed with 3 other people who have bad gastro and the nurse coming in and poking you every 3 hours? Like, I don't understand how we lack not just humanity, but the ability to sleep and heal in hospitals. And to me, this is like the most minor of those issues. But yeah, if we want people to be able to sit down next to their patients, we need to design better hospitals so that naturally happens. Because there's no way doctors are going to go looking for a chair to complete the rounds. It's just not the way life works.
That is true. We probably should point out that these doctors spend an average of 10.5 minutes with their patients, which if you spent 10.5 minutes with every patient, Justin, you'd never get through your day. So maybe we need to measure the amount of time it takes you to find the chair and then take it to the patient's bedside and see if the overall net gain's still there. But yeah, it's a tricky one. Quality over quantity. And yeah, completely agree. I don't even know if you need a chair, but just getting down to eye level with the patient is probably the most important thing for what we do in medicine. And as I said twice already, I've been in the MRI, so my knee doesn't let me squat anymore. So it's one of those things that we should just design better. And yep, if we can get down to eye level and talk to patients one-on-one, that's really what the trial should be showing.
Yeah, I don't squat for adult patients. But for pediatrics, I always try to squat and get down on a level, but it's a little embarrassing now, the groan that it takes from as I try to stand back up from squatting position. I'm going to have to come up with a different plan over the coming decade.
Or you just need some nebulized ketamine, Justin. That's all you need.
A little for you, a little for me. This is how I get through my shift. I really hope the college listen to our podcast.
If it's nebulized, then the whole room can have some. That's the best part. All right, mate. I think we've made it to the end. Another fascinating conversation. And if you want to see more of Justin, please go over and check out the YouTube channel, and you can see him in much shorter but high quality segments discussing a lot of really cool EBM stuff. If you're really keen to learn some fun ultrasound stuff, I also have a little YouTube channel that I've started up as well. So just look up me and you'll find my YouTube channel, and you can learn some basics of ultrasound. It's all free and open access medical education, which is what we're all about. So have a look. Justin, any last words?
No, hopefully you'll see you again next month. I'm not sure, this might not be a selling point for most of our audience, but we're going to try to be out a little bit more frequently. Can you imagine when we started this, it was called Articles of the Month from me, and we put out one of these every month for a little while. And now we're not hitting that mark, but we're going to try to get back to that and give you maybe smaller, more digestible, not hour-and-a-half long podcasts every month. So hopefully we'll be back again next month, and we'll have a little more nerdiness then.
All right, mate. Good to speak to you, and hopefully I'll see you sometime in April.
Take care, buddy.
Bye.